Welcome to the training program for medical officers and staff nurses on Ashadhara, the new program for hemoglobinopathies and hemophilia. The new program Ashadhara covers the treatment support program for hemophilia and hemoglobinopathies. Under hemoglobinopathies, the major diseases we take care of are sickle cell anemia and thalassemia. There is a web portal created by the state government of Kerala through National Health Mission for Ashadhara. And this works as a registry for patients and documenting patient care activities. So the hemophilia and hemoglobinopathy program, the background in the state of Kerala is as follows. The program started with the government support a decade back, and that started through various government orders. And these are all based on the advocacy efforts by patient groups. The first session, like the earlier 2012-13 onwards, this was covered under Karanya Benevolent Fund, supported by the Lotteries Department. Medicines were procured through Kerala Medical Service Corporation subsidiary Karanya Community Pharmacy, and the medicines are kept in the Karanya Community Pharmacies. With a prescription from any registered medical practitioner, any patient could have availed treatment, the medicines from Karanya Community Pharmacies, and they were taking the factors and other medicines required for hemophilia treatment. There are now organized programs for sickle cell anemia and thalassemia. The sickle cell anemia patients were supported under the National Health Mission program for sickle cell anemia, and thalasssemic children were being provided with some sort of support under the program RBSK. The hemophilia and hemoglobinopathies treatment were mostly provided by some physicians, and mostly were out of their interest through some of the medical colleges and some hospitals under the Health Services Department. Mostly the treatment were carried out through the medical colleges Trivandrum, Calicut, Thrissur and Kottayam. And one of the major center was the Hemophilia Treatment Center, Alua. So mostly the supportive and preventive treatment were provided through the Hemophilia Treatment Center, Alua. And the on-demand treatment was provided through various healthcare institutions across the state, and medicines were provided by Karanya Community Pharmacies. Ashadhara program launched in the state in 2020 August, and this was a comprehensive decentralized management program for hemophilia and hemoglobinopathies. And this was an initiative under the state blood cell of National Health Mission. Now there is a digital patient registry, as I told earlier. Ashadhara portal is ready. This can capture the patient information. All the patients were requested to register in the system, and the system will generate a unique ID for each patient, which will be unique for every patient, either it is hemophilia or sickle cell or thalasssemic patient. They will be, whenever they are provided with factor or any other medicine from any units, that information will be captured through the system. Patients can view their profile and their factor consumption or the treatment log using their login, which can be availed through the entering the portal through their mobile number and putting their OTP received in their registered mobile number. There are treatment support units across the state. Mostly it is the district daycare centers in all 14 districts. The list will be shown in following slides. And there are regional treatment centers like Hemophilia Treatment Center Alua, and one in SAT Hospital established in Trivandrum for the southern districts, and one other in the Calicut Medical College, the IMCH. And there is a research center proposed for Wayanad for hemoglobinopathies and sickle cell diseases. Along with this, a treatment protocol is published by the state government of Kerala for treating hemophilia based on the type of bleed, and the dosage prescriptions will be given to the patients as per the treatment protocol. E-Sanjeevani OPDs have started functioning, and it is available. The patient consultation will be available online on a daily basis and on all weekdays. Specialists and experts from the domain are attending the sessions. One dedicated staff nurse is posted in all district daycare centers as patient care coordinators. There is a technical committee formed at state level, which will be reviewing any technical aspect, including the individual high volume consumption of factor and other medications by patients. Prophylaxis for children started for any child less than 18 years with inhibitor and without inhibitor. All factor VIII and factor IX patients can avail their prophylaxis program, and already there are 200 children on regular prophylaxis. There are some regulations imparted to make patients adhere to the treatment protocol and state policies of an on-demand treatment protocol, which is published by the state government for adult patients. So overall, hemophilia and hemoglobinopathy management program in Kerala is a comprehensive decentralized program under the new cap of Ashadhara program. There are 10 district daycare centers and 4 hemophilia and hemoglobinopathy treatment centers, along with the regional, along with the research center is planned, and all the district daycare centers are established in all 14 districts. The major treatment support offered is on demand, and on demand means in case of an emergency, any bleed, the patient can avail treatment, and any child less than 18 years will get prophylaxis. So this is the list of the district daycare centers and hemophilia treatment centers. In addition to these centers, all government medical colleges, the major government medical colleges are having a multidisciplinary team functional. There is a nodal officer nominated from all the medical colleges, and specific treatments are available in all these medical colleges. Hemophilia treatment centers and the district daycare centers are equipped with a nodal officer. That person will be coordinating entire treatment procedures in that district with the support of the patient care coordinators, nurse posted, and other various stakeholders in the district. So under the program, district daycare centers and regional, there are different roles for each centers: district daycare centers, regional hemophilia treatment centers, medical college hospitals, taluk level hospitals, and in case PHCs and CHCs, the roles and responsibilities are defined. In the district daycare centers, there will be regular OPD on a weekly basis. This is a lab functional with specific capacities to do certain tests, which is required for hemophilia and other hemoglobinopathy patients. 4-bedded wards are identified, or dedicated 4 beds are identified in these hospitals to provide daycare therapies or daycare treatment. There will be data management, including patient registration. The prophylaxis program is run through these district daycare centers. Follow-up care for sickle cell and thalassemia patients are also being offered here. The transfusion services for thalassemia patients are also available in these centers. These centers will take care of specific measures to prevent disabilities and deformities of joints for patients affected. Regional hemophilia centers are the referral units where the patients can be referred from district daycare centers. These centers mostly will do the lab confirmation of diagnosis and follow-up tests. Any follow-up test required. There will be 10-bedded units, 10-bedded wards available. There are also all sort of activities which are there in the district daycare centers are also available. Additional facilities are mostly rehabilitation service and physiotherapy, which is made part of these regional treatment centers. Medical colleges will provide the comprehensive. They have a comprehensive team which includes different specialists. They will be managing the emergency complicated cases. They have lab facility for higher level management support. Then the prophylaxis of children will also can be affected through these medical colleges with prior approval. Sickle cell disease and thalassemia patients in crisis and in other emergencies are managed in the medical college hospitals. Now, taluk level hospitals are also introduced in the program, and they will be providing the emergency first dose for any patient presented with bleed in case of hemophilia, and the blood transfusion in case of thalassemia patients, and crisis management for sickle cell disease. Mostly the stabilization part will be taken care, and the cases will be referred to the higher centers like district daycare centers or regional hemophilia treatment centers or medical colleges. So any of these patients, if come for any other routine care like the NCD support or any other disease related routine care, they can approach any of the PHCs, family health centers or CHCs. So this is a table which shows the continuum of care, which starts from prevention, screening and diagnosis, treatment and prophylaxis, and rehabilitation, and different level, the centers at different levels, what all they are providing under these different headings. So mostly the medical colleges will be doing guidance in capacity building, research, training courses, super specialty nurses and healthcare workers, and all will be trained in these centers based on their capacity. Hemophilia treatment centers are the center of excellences. Capacity building program usually are being taken up through ALO HTC. They do some training courses. They help in content development. Then the family tree mapping is one of the area that we are expecting from hemophilia treatment centers and district daycare centers. Premarital counseling, capacity building for secondary palliative care deliveries providers, etc., are the major work that they do from the hemophilia treatment centers. District daycare centers are expected to provide health promotion, dissemination of IEC, awareness session, capacity building for primary palliative care delivery providers, etc. Under the diagnosis and screening, mostly the hemophilia treatment centers do advanced diagnostic facilities, and they are recognized as a reference lab. Advanced diagnostic facilities will be available in medical colleges, and the screening and early suspicion referral to higher centers are the responsibility of district daycare centers. When it comes to the treatment and prophylaxis, mostly the prophylaxis is done by the district daycare centers. They do the monitoring part and prophylaxis program, and on-demand primary care. The on-demand support is also provided through the district daycare centers. Specialized surgeries and other major things are being done through the medical college hospitals. Some sort of evaluation and like especially on the joint evaluation, those sort of things are being carried out through the hemophilia treatment centers. In the treatment part, Taluk hospitals have a role. As told earlier, they will be providing the first dose in case of an emergency. When somebody is presenting with a bleed, they will be giving appropriate treatment based on the treatment protocol provided, and prompt referral will be done. Rehabilitation part as well. Mostly the rehabilitation aspects are being taken up through the hemophilia treatment centers, the regional treatment centers. There are plans for partnership with various NGOs, specialist therapies like aquatherapy, which is they are already there in Alua, and all these things are the crux of rehabilitation processes. District daycare centers are providing home-based care and pain relief, palliative care linkages, all those sort of things. Some sort of PMR support through the district hospital physiatry unit and all will be provided by the district daycare centers. Now, about some of the concerns that and the doubts regarding the new program implementation part when that comes to the new 69 institutions. So in this case, a brief history to the changes. As I told earlier, the medicines were provided through Karunya Community Pharmacies earlier under the support of Karunya Benevolent Fund. When the Ashadhara program started, this became a project or a program under Health Department, and the medicines are started procured through KMSCL under EDL. So now the medicines are stored in or disbursed through the healthcare institutions rather than the Karunya Community Pharmacies. So the now medicines are available in all these hospitals. The medicines will be the channel for supply is like the district warehouses will supply medicines based on the intent and requirement by each designated hospital. As per the state policy, it will be provided only to the level of hospitals like Taluk hospitals. The reason being, they are the only 24/7 facilities. So only 24/7 facilities, that is the Taluk hospital, up to the level of Taluk hospitals, will have medicines for treating hemophilia and hemoglobinopathies. Once the supply comes to the institution store, it should be documented properly, considering the fact that most of them are costly medicines. Clear directions are issued by Director of Health Services through Additional Director Medical, how the medicines needs to be stored and how the substock should be issued and all. Every casualty department should have medicine available for emergency use. So a substock should be given to all these units, all the casualty departments in all Taluk level hospitals where the program is implemented. So once the medicine is available, the head nurse in charge should take the stock and keep under appropriate temperature. Like the cold storage should be maintained for all these medicines. Once the patient comes to the casualty on demand, that is with a bleed, most of the time the patients will be complaining pain or decreased or restricted movement in their joints, etc. Or in case of muscle bleed and all, there will be pain and other symptoms. Once the patient reports to the casualty medical officer or other doctors in charge of the units should write a prescription as per the state issued treatment protocol. There will be two considerations when you are issuing a prescription. One is the patient body weight and the type of bleed. So the treatment protocol issued is based on these two characteristics. Once the patient comes to the hospital casualty, once the prescription is issued, that will be presented to the nurse in charge, who will do all the right things and reconstruct the medicine and administer it to the patient. That is what the whole program will be doing. So now it is instructed that an additional second dose can be issued to the patient. So when that can be given, an additional one dose can be sent from all institutions. It is not only from the Taluk level hospital or the medical college or the district daycare center or regional treatment center. All the institutions can do that. They can send one dose to the patients in case if the treating doctor has a conviction that a second dose other than the infused dose is required for the appropriate management of the patient. So that means the usual dose is a BD dose other than factor 7. So in that case, if the doctor feels that it is appropriate to have a second dose and the patient is unable to come back due to any social reason, or the patient is unable to get admitted in the hospital, or the hospital have no facility to admit the patient, in that case, the second dose can be sent with the patient. Or in case of a serious bleed and the doctor feels that the patient needs a referral, in that case, it should not be provided and the patient needs to be referred appropriately. In case of a bedridden patient, one dose can be sent with a direction to use it through the local palliative care team. All these files sent home should be documented separately and make sure that use files are returned as directed and the utilization is obtained through the responsible team member. And about the storage of use files, all the used empty vials should be kept in the hospital for a minimum period of 1 month or till the store superintendent verify and reconcile the stock. The returned vials from patients who are allowed to carry one dose should be counted and documented by cross-verifying the batch number of the medicine issued. The vials may be discarded as per the biomedical waste management protocol after proper documentation. So this is again an important aspect. The vial should be counted and the usage should be based on the records and the prescriptions. It should be reconciled before discarding the used files. So documentation and reporting of factories is a very important aspect considering the high value nature of the medicines that we are using for the program. So there will be a reporting format for documenting the factory issue, details from emergency department and or the ward of a government hospital that we will be discussing in the next 2 slides. So this is the utilization certificate format, which it has 3 parts. This is the first part where once the single dose is issued to the patient, that will be documented in this part. And the name of the doctor issued the medicine and name of the hospital issued the medicine should be written along with the signature of the doctor and the staff nurse who are providing it. Because it will be done from the casualties. So it will be provided from the casualty and this will reduce the stock available in the casualty. It will not be provided, it will not be disbursed from the pharmacy. The files that will be given to the patient to take home will be provided from the casualty only. So once the dose is issued to the patient, the issuing doctor and the nurse should know where they will be taking it. This information should be collected from the patient and they in turn, whoever is administering the dosage should fill the second part of the utilization form and with their, if it is a nurse or a doctor, in their registration number also should be included in the form. And the third part is a patient declaration stating that for their child or for themselves, they have administered or they use the medicine. This is the form that we will be using in hospitals for documenting the stock. It is serial number, date and time, name of the patient, gender and age, weight of the patient. This is very important. Ashadhara ID is a unique ID that is provided to all the staff, all the units and all the patients. Location, type of bleed that will be there in the OPG or the prescription. Dose or vials used, there will be 2 types. One is infused in the hospital as a stat dose and the vials given in hand. That should be documented separately. If the 4 vials are infused in the hospital and 4 vials are sent home, it will be 4 and 4. Name of nurse in charge, signature, and there you can take out the sticker from the vial and paste it in the register there. And different stakeholders have different roles and responsibilities, and that is also very well written in the orders issue. All hospital superintendents have their own responsibilities for this program, which clearly spells that they must ensure the factors and other drugs provided are available in the casualty department without any interruption through maintaining sub-stock intended and issued from main stock in the pharmacy or store. The superintendent of each hospital should review the program, including stock and supply on a monthly basis, and furnish a report to whether if it's a medical college to DME or any health services institution to DHS via DMO with a copy to the district nodal officer for district daycare center. The roles and responsibilities of pharmacists is also clearly mentioned. So the pharmacist or store superintendent are instructed to maintain separate stock for these drugs, place intent based on the requirement and utilization to the chemistry warehouse. So if you have 40 numbers allocated are the 40 numbers of factor 8. Say it is issued to the hospital. Now, before depleting the whole stock, like 20 as already used, and by the item itself, the store superintendent should give an intent to the chemistry warehouse so that it is replenished. Then they'll be issuing sub-stock based on demand and utilization from casualty, making sure that there is a continuous supply. And if you have a supply of 40 vials of factor 8, and you will be issuing 20 to the casualty department as a sub-stock, and the head nurse is giving a report stating that out of that 15 are used. Immediately, the rest of the numbers, maybe 10 or 15, should be released to the sub-stock of casualty immediately, and make sure that a continuous supply is ensured. All casualty medical officers should be oriented on the program and state protocol. The doctors should be specifically advised to prescribe the drug as per the state-led treatment protocol, and to ensure the drug is infused in the hospital itself. Again, this is the responsibility of the hospital superintendent. So all the store pharmacists and store superintendent should be instructed to do the above 2 points by the superintendent of the hospital. The head nurse or nurse in charge should be entrusted to keep the stock updated and ensure adequate stock in the casualty at any point by properly replenishing the stock. It's already discussed. No medicine prophylaxis for any patient shall be given from any unit other than the district daycare center or an HTC, or even some other medical colleges are also allowed to do that. But other than that, none of the taluk hospitals or other medical colleges are not allowed to initiate prophylaxis or continue the prophylaxis for already initiated patients from their stock. Other staff nurses or casualty nurses should be trained to do infusion of different factors, medicines before administering to the patient. They should report the utilization of drug from the casualty through the Android app provided in the Ashadhara portal. There is an Android app provided to the hospitals, which can be installed in the Android mobile phones. The stock should be not the stock, but whenever there is a prescription coming for a patient, the details should be entered into the Android app. The quantity of medicine issued should be reported in the same day by the same staff issued the medicine from the hospital. Details on using the Android app and how the stock should be reported, etc., will be given in a separate video. Thank you.